Bismillahirrahmanirrahim. Assalamu alaikum. I am Professor Athiya Rahman, Head of the Department of Dermatology, PNS SHIFA and Beria University. First of all, I would genuinely apologize to all of you for starting this CPC late, but it was due to some technical issues, and we now hope that it will go smoothly. And I welcome you all to the 17th Clinicopathological Conference, and it is the third conference of our institutes since the inception of this academic activity. These CPCs provide us a unique opportunity to deepen our understanding of the complex relationship between clinical medicines and diagnostic sciences. We look forward to an insightful and fruitful learning experience. So let's begin. I would first invite the first presenter, Dr. Nur Sabah.
Assalamu alaikum and good morning to everybody. My name is Dr. Nur Sabah, resident dermatology, PNS SHIFA Hospital. I am honored to present my case under supervision of Dr. Athiya Rahman. My case is of a Pemphigus vulgaris patient with visual disturbance. My CPC comprises of case presentation, case discussion, and conclusion. My patient, a young 29-year-old male, resident of Punjab, security official by profession, presented to us in the dermatology OPD on 18th of April 2024 with complaints of multiple crusted erosions on his body for 3 months. My patient, according to him, he was in his usual state of health 3 months back. Then he suddenly developed multiple fluid-filled vesicles on his body. On examination, there were multiple flaccid blisters, hemorrhagic crusted erosions, predominantly present on his scalp, face, neck, upper limbs, and trunk. His oral mucosa was also involved, comprising multiple flaccid blisters, making chewing painful. The blisters would rupture spontaneously, leaving behind painful raw erosions. His eyes, nostrils, and genitalia were unaffected. He was leading an active life prior to these cutaneous lesions, and no significant drug history was given by my patient prior to these eruptions. His past medical and past surgical history was not contributory. His personal history was unremarkable. His family history and drug history were also not contributory. He belonged to a lower middle class socioeconomic status, and my patient did not give any significant travel history. His vitals were within normal range. His general physical examination was also unremarkable. His systemic review was unremarkable. Now, this is the clinical image of my patient showing well-defined multiple crusted plaques along with few erosions. There was also serous discharge present along with marked post-inflammatory hyperpigmentation involving his whole back. We made 3 differential diagnoses based on the clinical picture, which were Pemphigus vulgaris, IgA pemphigus, and subcorneal pustular dermatosis. His lab investigations were normal, and his hepatitis B and C status was also negative. This is the histopathological image of the lesions of my patient, and it shows intraepidermal split. To be more precise, the split was at suprabasal level, comprising of acantholytic cells, and on a closer view of the dermis, we could appreciate a perivascular infiltrate of lymphocytes, histiocytes, neutrophils, and eosinophils. My patient was not affording, hence we could not perform his direct immunofluorescence. Now, based on the brief history of my patient, his clinical examination, and all the investigations, we diagnosed him as Pemphigus vulgaris. The patient was started on high-dose prednisone 60 mg daily along with steroid-sparing agent mycophenolate mofetil 1 gram OD. However, on the 21st day of his treatment, he developed a sudden blurring of vision in the left eye, and the vision in the right eye was normal. An urgent referral of ophthalmologist was sought. His visual acuity test was carried out, and the visual acuity of his left eye showed loss of 1 line, which improved after refraction to 6/6. The visual acuity in this right eye was normal. Now, seeing these findings and knowing that the patient was on high-dose corticosteroids or worthy vitreoretinal surgeon, she decided to carry out the optical coherence tomography of my patient. This is the OCT image of the patient's retina. Now you can see the left retina, there is marked edema, collection of fluid between the retinal layers, and the overall thickness of the left retina is increased to 661 microns, whereas the normal is 250 microns. His right retina shows no edema and no normal thickness of the retinal layer. His MTT was then carried out, that comprised of vitreoretinal surgeon, medical specialist, dermatologist, and the ophthalmologist ascribed his central serous chorioretinopathy most likely due to high dose of steroids. She advised us to omit the drug instantaneously. However, keeping in mind that Pemphigus vulgaris is a life-threatening condition and steroids playing a key role in its management, and also knowing about the hypothalamic pituitary excess suppression of my patient, we could not omit this vital drug instantaneously. We decided on a more rapid tapering than our initial plan and reduced 5 mg every week till the patient reached a dose of 15 mg per day, followed by a reduction of 2.5 mg per week. The patient now is currently on 10 mg per day along with mycophenolate mofetil 1.5 gram per day, and we plan to taper it slowly 1 mg per week till 5 mg day dose is reached. The patient is in remission on current medication. Now the case discussion. Central serous chorioretinopathy is basically a pathology of retina. It is characterized by localized serous detachment of the neurosensory retina at the macula due to damage to the pigmentary retinal layer. It mostly affects males of 20 to 50 years of age. Our retina is comprised of specialized cells, the retinal pigment epithelial cells, and there is a blood vasculature network running beneath the retinal layer that is known as choroid. Whenever there is any abnormality to the function of the retinal pigment epithelial cells and the choroid, so this results in fluid accumulation. And when it occurs at the level of macula, it results in painful blurring of central vision that occurred with our patient. Some of the symptoms of CSCR are fairly sudden onset of blurry vision in the eye, a blurry dim blind spot in the center of vision, objects appearing miniature from the affected eye, distorted straight lines, and washed out appearance of colors. Researchers have identified few risk factors of the condition. Among the common ones are stress, both physical and emotional, type A personality, obstructive sleep apnea, smoking, caffeine consumption, comorbids like high blood pressure, Cushing syndrome, and steroids, mainly corticosteroids given by any route, be it oral, intravenous, intranasal, or intraarticular. Now the disease course. Most people recover from this complication within 3 to 6 months without any need of treatment. Between 30 to 50% people will experience a further episode of CSCR in either the same or the other eye. CSCR, which lasts up to 12 months, may require treatment because of the continual damage to the retinal pigment epithelial cells and swelling of the retinal layers, which can result in different types of complications like vision loss and even bullous detachment of the retina. In majority of cases, it settles down within 3 to 6 months that occurred with our patient. Any triggers such as corticosteroid use may be reviewed and stopped. Some of the treating modalities are photodynamic therapy, thermal laser, micropulse laser. Outcome. Our patient, however, did not require any of the above mentioned treatment modalities for his complication. His CSCR was reverted successfully after we tapered the dose of corticosteroids. The blood vision in his left eye was improved, and after tapering corticosteroids, his OCT was repeated after 2 months, and you can see that both the retinas, there is no fluid accumulation, no retinal edema, and the retinal thickness has also returned to normal, that is 250 microns. This is the clinical image of my patient in remission. Only post-inflammatory hyperpigmentation is left. Literature review. Now, our case is a little rare because the complication which occurred to our patient is not usually encountered and even reported in the dermatological OPDs. And there are very few case reports in the literature as well. We came across one case report of recurrent central serous retinopathy with permanent vision loss in a US naval fighter pilot. It was published in September-October 2018. This pilot developed central serous chorioretinopathy in his right eye due to high dose of corticosteroid 60 mg per day, which was prescribed to him by his general physician for contact dermatitis. And on the 12th day of his treatment, he developed this complication. Unfortunately, even after omitting the drugs, the complication of his eye did not revert, and he suffered from a permanent visual defect in the right eye. Conclusion. Our patient suffered from a unique and rare side effect of steroid, which is central serous chorioretinopathy. Prompt identification of this ophthalmic condition and modification in treatment plan led to the resolution of his condition. Dermatologists need to be aware of this rare complication, which, if left undiagnosed and untreated, may lead to permanent visual defect. These are my references. Now, I would like to invite my supervisor for comments. Thank you.
Thank you very much, Dr. Noor, for an excellent case presentation and discussion. And as she has highlighted it herself, that the purpose of presenting this case was to make us aware of the rare complication CSCR, chronic serous chorioretinopathy, which hasn't been reported in dermatology medical literature before. We do use high dose corticosteroids often, but even in my practice, I have seen this complication for the first time. And while we were doing the literature review, it has been reported for different conditions like steroid use in facial nerve palsy or even intranasal steroid drops or intraarticular, but not in immunobullous disorder, to our surprise, because we do use high-dose corticosteroids. Rituximab is the drug of choice in Pemphigus vulgaris, but obviously in resource-stricken economies like ours, often we aren't able to use it, but we have counseled the patient that if his condition relapses, that then he's a candidate for rituximab, and he would have to arrange this drug because we cannot really experiment by giving him high dose of steroids again. So I would welcome any questions from our audience. If there are any questions or comments before proceeding to our case number 2, invite the second presenter to come forward.
Bismillahirrahmanirrahim. Assalamu alaikum and good morning, everyone. I am Dr. Rihana Batul, resident at Dermatology, PNS SHIFA. I am honored to present this case under kind supervision of Dr. Mohammad Mudassir. This is the sequence of my presentation today. 77 years old male, married, retired banker, resident of Karachi with known comorbidities, diabetes, hypertension, and CKD grade 1, presented on 18 March 2024 in OPD with complaint of generalized severe itching for the last 2 years, red raised lesion over trunk and lower limb for the last 9 months. History of presenting illness. The patient developed severe generalized itching on and off for the last 2 years without any diurnal variation and no relevant family history, disturbing his sleep, and was temporarily relieved by oral antihistamine. This was associated with development of generalized red raised lesion over the trunk, and along with crops of recurrent papules and nodules, with few lesions are ulcerating and crusting. No history of fever, night sweats, or weight loss. No history of TB or TB contact. These lesions were unresponsive to topical steroids. Systemic inquiry was not significant. Past medical history was not contributory. He had hernioplasty back in 1998. These are his regular medications. Family history was not significant. Patient was non-smoker with a good appetite and no history of allergies. Sleep was disturbed due to severe itching. Dermatology life quality index score was 8, which indicates quality of life is moderately affected by the disease. On physical examination, an elderly male of average height and build was vitally stable on arrival. Subvitals were also normal. Lymph nodes were not palpable. Cutaneous examination is shown in the picture revealed a generalized erythematous ill-defined indurated plaques over the trunk and arms. Additionally, there were multiple eroded papules as well as ulcerated and crusted nodules primarily located over the shoulder, arms, and bilateral lower limb. The picture showing eroded and ulcerated nodules. Rest of cutaneous examination was unremarkable. Review of system was unremarkable. Now summarizing my case, 77-year-old male, known case of diabetes, hypertension, and CKD, well controlled on oral medications, presented to us with on and off severe itching for the last 2 years, along with red raised lesion over body for the last 9 months. Examination revealed generalized, ill-defined erythematous indurated plaque with ulcerated papillonecrotic lesions over trunk, arms, and lower limb. No systemic involvement, lymph nodes not palpable. Considering the patient's history and clinical examination finding, the differential diagnoses were included cutaneous T-cell lymphoma, acquired reactive perforating collagenoses, pityriasis lichenoides at varioliformis acuta, and papillonecrotic tuberculosis. Investigations were done. CBC showed elevated TLC count of 15,000 microliter. Rest of parameters were normal. Peripheral smear did not reveal any atypical lymphocytes. Serum LDH, ESR, chest X-ray, and ultrasound abdomen were also normal. Rest of biochemical profile were within normal limits. So the skin biopsy from the abdominal plaque was done, and it revealed hyperkeratosis, parakeratosis, and focal degeneration, but no evidence of epidermotropism or portary microabscesses in the dermis. In the epidermis, the dermis show a large infiltrate of a few large atypical lymphoid cells, lymphocytes, histiocytes, and eosinophils. Immunohistochemistry was done. The dermal infiltrates were positive for CD3 and CD4, along with focal positivity for CD8, indicating a mixed infiltrate of helper and cytotoxic T cells in the dermis. The large atypical cells were positive for CD30 with a background positivity for CD7. This immunopathology was suggestive of primary CD30 positive lymphoproliferative disorder, including lymphomatoid papulosis and anaplastic large cell lymphoma. However, given the history and the clinical presentation of our patient, the strong suspicion of mycosis fungoides, we decided to do the rebiopsy, and also additional staining was requested. The rebiopsy was done from nodule over the leg, which showed the similar epidermal changes with no evidence of epidermotropism. The dermis show a wedge-shaped, moderate, perivascular and interstitial infiltrate with numerous atypical large cells with a few mature lymphocytes and occasional eosinophils and histiocytes. Immunohistochemistry showed the large atypical cells were positive for CD30, CD7, and CD4. However, it is negative for EMA and MAM1 and also negative for PAX5 and CD56. These positive and negative markers rule out primary cutaneous and systemic anaplastic large cell lymphoma and mycosis fungoides. So the final diagnosis was lymphomatoid papulosis type A. The patient was started on methotrexate 7.5 mg once weekly, along with narrowband UVB therapy thrice weekly, and oral antihistamines. Patient was regularly followed up. These are the picture of patient before and after the 8 week of therapy, and we can notice a marked improvement in the itching as well as the erythema and induration of the patient, along with the resolution of papillonecrotic nodules, leaving few hyperpigmented atrophic scars. Patient was counseled regarding the prognosis of condition, and he was advised to maintain a regular follow-up appointment. Now, case discussion. WHO classified lymphomatoid papulosis along with primary cutaneous anaplastic large cell lymphoma in CD30 positive lymphoproliferative disorder. It is a chronic recurrent self-healing papillonecrotic lesion. The exact etiology was unknown. The overall incidence is 12% of all cutaneous lymphoma. It is 35 to the median age is 35 to 45 years, and male is more commonly affected than female. Pathology showed mixed dermal infiltrate of atypical lymphocyte with large nuclei, relatively late epidermotropism, and captured microabscesses. 5 histological subtypes were identified, including type A, B, C, D, and type E, which is an angioinvasive pattern. Type A showed a superficial, less than 75% large CD30 positive cells. Type B mimics mycosis fungoides, and it shows epidermotropism with CD30 negative and CD4 positive cells. Type C mimics anaplastic large cell lymphoma, showing a dense greater than 75% CD30 positive lymphocytes. And type D resembles aggressive epidermotropic cytotoxic T cell lymphoma, having CD8 positive and CD30 positive lymphocytes. These are the positive and negative markers of lymphomatoid papulosis. Colonal rearrangement of TCR genes found in approximately 40 to 100% of cases. Clinical feature: recurrent crops of papules. Papillonecrotic lesion primarily affects the trunk. Lesion grows rapidly. These are different morphological patterns reported in literature, including solitary lymphomatoid papulosis, papillonodular, ulcerating type, diffuse papillar type, and borderline and plaque type variants. Lesion regress within 2 to 12 weeks, leaving hyperpigmented, and atrophic scarring. Differential diagnosis includes CD30 positive lymphoproliferative diseases and CD30 positive inflammatory and infectious diseases, including primary cutaneous anaplastic large cell lymphoma, transformed MF, adult T cell leukemia and lymphoma, Hodgkin lymphoma, and other lymphoid neoplasm. And infectious disease include pityriasis lichenoides, lymphomatoid drug eruptions, and reaction to arthropod bites. Investigation: a thorough cutaneous and systemic examination along with a skin biopsy and immunohistochemistry is essential as the first step in the diagnosis. Baseline blood test, CBC, biochemistry, and LDH and imaging studies are necessary if secondary lymphoma is suspected. Disease course and prognosis usually require a long-term follow-up as 5 to 20% of cases progress to aggressive lymphomas, including CD30 large cell lymphoma, MF, and Hodgkin disease. Coexistence with MF is relatively common. Management options are low-dose radiotherapy, narrowband UVB therapy, and PUA, low-dose weekly oral methotrexate, oral dapsone, retinoids, and interferon. Now, literature review. A review article published in Cells in 2022, it focuses on the etiopathogenesis, diagnosis, and treatment strategies of lymphomatoid papulosis. This study highlights the importance of distinguishing lymphomatoid papulosis from other lymphoproliferative disorders with a thorough, accurate histopathological and immunohistochemical evaluation. Also, it highlights that the lymphomatoid papulosis requires lifelong follow-up. Another study in which a cohort of 504 patients were followed for a median of 120 months, and it showed that 15.5% of patients developed other hematological malignancies. It also highlights that mycosis fungoides was the most common, and 13 patients had coexistence of MF with lymphomatoid papulosis. This is a case report published in which a 59-year-old male with non-case of Hodgkin lymphoma developed mycosis fungoides and lymphomatoid papulosis at the same time. Picture of the patient where the abdominal plaque showing histology of mycosis fungoides and the nodules, it showed histology of lymphomatoid papulosis. Concluding my presentation, lymphomatoid papulosis is a unique condition and have a paradoxical nature. It is clinically benign but histopathologically malignant. It mimics several diseases, making clinical, histopathological, and immunophenotypic evaluation crucial to avoid misdiagnosis. Careful monitoring and follow-up is essential to assess the potential progression to the more aggressive lymphomas. These are the references I used. Now, I would like to invite my worthy supervisor, Dr. Mohammad Mudassir, to provide his expert insight into this case. Thank you so much.
First of all, I must congratulate Dr. Hana for his excellent presentation. For the reason for selecting is this case was because of this rare condition, which usually not presenting so frequently in ROPD. And this particularly this case, it presents with the erythematous plaques on the abdomen and ulcerated nodules on the lower limbs. So our first diagnosis was reacting perforating collagenoses. And later on, when the biopsy was taken from the abdomen, and it turned out to be CD30 infiltrative. So later on, we discussed the case with the HOD and the histopathology colleagues, and the rebiopsy just confirmed the diagnosis of lymphomatoid papulosis. As we know that the key in this particular patient, we have to keep a long follow-up, so the patient is counseled accordingly, and we will see the patient and see the progress if it transform into any malignancy or not. And if there are any questions, you may ask. So I would like to call our next presenter, Dr. Sarah.
Assalamu alaikum. Worthy head of department, consultants, and my dear fellow colleagues. This is Dr. Sarah, resident dermatology. I'm going to present a rare case of child with droop vesicles under kind supervision of Dr. Shakila Junaid. The components of my presentation will be case presentation, case discussion, literature review, and conclusion. Now, the case presentation, a 3-year-old baby boy, resident of Mirpur Khasin, presented to dermatology OPD on 12th of October 2023 with clusters of multiple clear to hemorrhagic fluid-filled vesicles on left leg since birth. According to the statement of patient's mother, these fluid-filled lesions are present since birth, which have been increasing gradually in size. These are not associated with pain, fever, itching, or trauma, with normal milestones and vaccinated as per EPI protocol. These lesions are associated with change in his length and breadth of the affected limb over the time, no aggravating or relieving factors, not affecting daily life activities. Past history. Past surgical history was significant as patient underwent surgical excision for these lesions when he was 6 months old, but followed by the recurrence of disease. Systemic review was unremarkable. Physical examination. A healthy looking toddler of average height, cooperative, well oriented to time, place, and person with no obvious distress, with vitals on presentation were blood pressure of 110 by 80 millimeter of mercury, pulse rate of 76 beats per minute, respiratory rate of 18 beats per minute, and temperature of 98.6 Fahrenheit. General physical examination was unremarkable. On cutaneous examination, there were multiple groups of translucent to hemorrhagic fluid-filled vesicles, largest one approximately measuring 3 by 4 centimeter in diameter on the left leg with characteristic frog spawn appearance. Lesions were soft, compressible, and non-tender, no palpable lymph nodes or other skin lesions, with normal range of motion and muscle strength in the affected leg. Affected limb girth was approximately 1.4 centimeter and length was approximately 0.5 centimeter greater than normal limb. On extending the examination, the dermoscopy showed light brown to violet lacunae surrounded by pale septa, areas of varying yellowish white to diffuse rose, fine linear vessels, with a hypopyon-like transition from a light color on the upper portion to red-violet in the lower portion. Systemic examination was unremarkable. Now the case summary. A 3-year-old baby boy with history of multiple groups of translucent hemorrhagic fluid-filled vesicles on lower limbs since birth, with history of some serious discharge from the lesions, with characteristic of frog spawn appearance and associated with slight changes in his limb length and limb girth. Differential diagnosis. First DD were Lymphangioma circumscriptum, Klippel-Tononi syndrome, as it was associated with limb length discrepancy, Park-Weber syndrome, and Clove syndrome. Investigations. The routine baseline investigations, including complete blood count, liver function test, renal function test, coagulation profile, viral markers, and chest X-ray were within normal limit. With ultrasound Doppler showed serpiginous channels with low flow velocity and no color on Doppler studies. Lesions were associated with soft tissue mass of 1.6 into 0.4 centimeter with no vascularity, with no evidence of DVT. Contrast enhanced MRI showed dilated vascular channels in subcutaneous tissue with extension between muscular compartments of thigh and leg with soft tissue edema. There was no intraosseous extension with dilated torsional vessels seen with sluggish flow on color Doppler ultrasonography with no evidence of phlebolith on X-ray or cortical break or fracture line was noted. Histopathology showed epidermis shows hyperkeratosis, follicular plugging, irregular thinning, acanthosis and spongiosis, with superficial dermis showing proliferation of dilated thin walled vessels lined by flat endothelial cells and filled with RBCs. These were the pictures of my patient. The immunohistochemistry showed podoplenin D240 positive in lymphatics and CD34 weak positive in lymphatics. Final diagnosis: on the basis of clinical history and all investigations, we concluded the diagnosis of lymphangiomas circumscriptum. Management: as recurrence is common with excisions, so we opted for sclerotherapy with bleomycin or hypertonic saline, or the second treatment option, oral sildenafil. Topic discussion. The lymphangioma circumscriptum is in common uses to describe lymphatic malformation. Strictly, a lymphangioma should be a growing lymphatic tumor involving proliferating lymphatic endothelium. They grow only by expansion or distension, but not by proliferation. The types of lymphatic malformations are macrocystic or deep, microcystic or superficial. The lymphangiomas circumscriptum is a term best reserved for lymphatic malformation that is localized to an area of skin, subcutaneous tissue, or sometimes muscles. Incidence: lymphatic malformations account for 4% of all vascular malformations and 25% of benign vascular growths in the children. Approximately 75% present at the birth, while the remainder present by 2 years of age. Pathophysiology: the lymphatic malformations can be atruncular, the isolated lesions disconnected from nearby normal lymphatic vessels, or the truncular can be connected to draining lymphatics, in which case the lymphedema will be featured. Clinical presentation: lymphangiomas circumscriptum manifests at birth or during infancy with localized subcutaneous swelling or as a group of translucent fluid-filled vesicles resembling frog spawn on skin. The commonest sites are axillary folds, shoulders, flank, proximal parts of the limbs, and perineum. They may be translucent when the overlying epidermis is thin or may appear red to violet when they contain blood. They may appear extremely warty and lesions can be mistakenly taken for viral warts. Lymphatic malformation can be part of syndromes such as Klippel-Tononi syndrome, Proteus syndrome, or Clove syndrome. Differential diagnosis: vascular birthmark, vascular malformations, hematomas or tumors, or viral warts. Investigations: the histopathology showing dilated lymphatic vessels and endothelial lining stained for CD31 and D240. Imaging: MRI or CT scan to rule out deeper lymphatic involvement. Ultrasonography to assess the lesion depth and surrounding tissue involvement. And lymphosphingologography, normal in atruncular lymphatic malformations but abnormal in truncular lymphatic malformations. Management: the conservative for asymptomatic lesions, sclerotherapy is mainstay of treatment for macrocystic lymphatic malformations, while sclerotherapy of microcystic lesions with bleomycin is effective and safe, with complete response in 38% of the patients and partial response in 58% of the individuals. Surgical excision or debulking procedures and compression garment for truncular lymphatic malformations. Second-line treatment options are oral sildenafil that can reduce lymphatic malformation volume and symptoms. Third line with sirolimus or alpelisib. Complications and comorbidities: lymphoria, ulceration, infection are the most common complications, or the obstruction of upper airways, infection, trauma, intracystic hemorrhage, pain due to the infection, or lymph thrombosis. Extensive lymphatic malformation can lead to conjunctive coagulopathy. Prognosis: generally good with proper treatment and management. They may recur after treatment, so regular follow-up is recommended. Now the literature review. This is a case report of lymphangiomas circumscriptum in the scrotum published from Surgical Department of Aga Khan University Hospital in 2021. With conclusion of complete excision of involved area is important to prevent the recurrence. The involvement of tissue as shown by radiology and histopathology is generally wider and deeper compared to the clinical assessment. So therefore, excision should include all subcutaneous tissue down to the fascia. Another case report of lymphangiomas circumscriptum in already diagnosed case of KTS syndrome published in Beijing, China in 2017 with a 31-year-old female who had been diagnosed with KTS but presented with oozy, painful, chronic progressive lesions over right lip images over the 4 years. On workup, this confirmed the diagnosis of lymphangiomas circumscriptum. This was another clinical case report showing cutaneous lymphangiomas circumscriptum, the relevance of clinical, dermoscopic, radiological, and histopathological assessment. These were my references. Key takeaways of my presentations are the lymphangiomas circumscriptum should be considered in differential diagnosis of vesicular skin lesion. Histopathological examination is essential for diagnosis, which shows dilated lymphatic channels and vessels. Treatment options include surgical excision, sclerotherapy, or oral sildenafil. Multidisciplinary management approach can improve the treatment outcome, and regular monitoring is recommended. That concludes my presentation. I thank you all for your patient listening. Now I would like to invite my worthy supervisor, Ma'am Shakila Junaid, for her final comments or insights. Thank you.
Assalamu alaikum. And thank you so much, Dr. Sara, for wonderful presentation. This case was unique and challenging for us because, first of all, the diagnosis was challenging for us because, as we know, lymphangiomas circumscriptum is in various cases it is associated with the other syndromes, as earlier mentioned by Dr. Sara. So we widely investigated this patient to reach the diagnosis, and we finally concluded that this patient is having lymphangiomas circumscriptum, which is not associated with any syndrome. And the second challenge was management. As this patient already underwent the surgical excision followed by the recurrence of the disease, and we know that after surgery, their recurrence rate is very high because of deeper extension of the lymphatic channels into the muscles and into the underlying structures. So recurrence rate is very high. So now we are planning to start this patient either on sclerotherapy or sildenafil. We will discuss this plan with the parents on further follow-up. This patient was the case was already also discussed with the pediatric surgeon, and he also agree with the plan of conservative management rather than going for a surgical excision again, considering the fact that the recurrence is high in this case. So any questions are welcomed. Okay, now I want to invite our fourth presenter, Dr. Afshan Kiran, for her presentation. Thank you.
Assalamu alaikum, everyone. I'm Dr. Afshan Kiran, Resident Dermatology, PNS SHIFA Hospital. Under the kind supervision of Dr. Sadaf Khari, I'm honored to present this case in today's Clinicopathological conference. Just a brief outline of today's presentation, starting with the case presentation, followed by case discussion with the help of literature review, and then finally we will conclude this presentation. So my case is of 27-year-old male with no known comorbid, unmarried, resident of Karachi, security guard by profession, presented to us via dermatology OPD with a complaint of slowly growing swelling on dorsum of the right toe with discharge for around 5 years. According to my patient, he was in usual state of health 5 years back when he first noticed a solitary small red grayish lesion or dorsal aspect of the second toe. Over the period of 5 years, it progressively increased in size and evolved into a nodular swelling, extending towards the first wab space and involving the plantar aspect of the foot as well. It was associated with mild discomfort and pain on walking, along with on and off serosanguous discharge. There is no history of other body surface area involved, no history of fever, weight loss, night sweat, or history of joint pain, mobility restriction. There is no history of trauma or insect bite or no aggravating factors. Systemic review was unremarkable. Patient also visited general surgeon for the same complaint in the past, and there he was treated conservatively, but the lesion did not improve. However, past surgical and drug history was unremarkable. Family history was unremarkable for a similar disease. Personal history, travel, allergic history was unremarkable as well. He belonged to a lower middle class status with life quality index of 8. On physical examination, he was a young male of average height and build and was vitally stable.
Journal physical examination, there was a sub-centimeter right inguinal lymph node was present. On cutaneous examination, there was a fur nodular swelling on dorsum of right foot involving the base of second toe and extending onto the first interdigital wax space, which was extending to the plantar aspect of the foot. It was 4 into 4 centimeter with multiple discharging sinuses. Mildly tender toe plantar and dorsiflexion was positive. Distal neurovascularity was intact. Rest of the cutaneous and systemic examination was unremarkable. So, on the basis of history and clinical examination, following differential diagnoses were made, which were starting with the primary cutaneous actinomycosis, deep mycosis, mycetoma, and down the list tuberculosis varicosa cutis. Baseline lab workup was performed as a treatment protocol and they were in normal range, along with the Montauk's test and gene expert. Skin biopsy for histopathology was performed. That was initially inconclusive. So the deep tissue biopsy was planned and general surgeon was taken on board. True-cut skin biopsy for histopathology performed, which showed the fibrocollagenous tissue with foci of abscesses having a large basophilic filamentous bacterial aggregates with dense mixed inflammatory infiltrates, that you can appreciate in the picture. So just to summarize my case, this is a case of 27-year-old male with 5-year history of slowly growing nodular swelling on the right foot second toe with plantar surface involvement, with no history of trauma or insect bite. Biopsy shows basophilic filamentous bacterial aggregates. Diagnosis of cutaneous actinomycosis was made on basis of clinical and histopathological findings. To see the extent of the disease, MRI right foot IV contrast was planned and done, which showed the multilobulated lesion completely encircling base of second proximal phalanx, partially encircling the base of third proximal phalanx with involvement of first, second, and third WAP spaces. For optimal patient management, multidisciplinary meeting was conducted, which was attended by the mentioned specialties on your screens. Based on the consensus made by multidisciplinary team, following treatment plan was advised, and that was to start patient with injection ampicillin 2 gram IV 6 hourly for 2 weeks, followed by increment dose of 3 gram IV 6 hourly for further 6 weeks, with the partial debulking of the lesion and 3 monthly MRI right foot follow-up. So after 8 weeks of treatment, patient only responded partially to the treatment, with draining sinuses resolved and reduced in size of the swelling around 10 to 15%. Here you can see or appreciate the clinical improvement after 8 weeks of treatment. As per improving clinical condition, following treatment plans were devised for patient, and that was to switch patient to oral amoxicillin 2 gram BD for a longer period of time, that was 1 to 2 years, with repeat MRI right foot after 3 months of treatment, with 2 monthly follow-up in dermatology and infectious disease OPD, with the maintenance of right foot hygiene care. If this condition does not improve after this regime, doxycycline along with the debulking can be chosen or considered for the patient. Otherwise, he might be a potential candidate for toe or forefoot amputation. So the case discussion. Actinomycosis is a rare chronic suppurative bacterial infection which is caused by anaerobic bacteria, primarily of genus Actinomyces. There are 5 clinical subtypes: cervicofacial, pelvic, thoracic, abdominal, and primary cutaneous, like in our case. So the risk factors include immunodeficiency, diabetes mellitus, poor oral hygiene, sepsis, or use of intrauterine or intravaginal devices, trauma, and many more. So to diagnose this case or the disease, deep skin biopsies are usually performed and act as a gold standard. To see the microscopic sulfur granules and other confirmatory test is PCR as well. The first-line treatment for actinomycosis is usually penicillin, or ceftriaxone can also be used with the recommended doses. In transition to oral therapy, penicillin B or amoxicillin can be used. Alternative to that, doxycycline macrolide can also be used along with a surgical management with adjunct therapy. So now the literature review. This is a case report published in 2017 of 55-year-old female as a case of primary cutaneous actinomycosis of the lower limb. She was initially treated as a case of cutaneous tuberculosis and mycetoma based on the clinical differential diagnosis. But after the deep skin biopsy, she revealed a primary cutaneous actinomycosis, for which she was given penicillin therapy, and patient improved after 3 months of therapy. She was also given trial of antituberculotic drug, but she didn't respond before the biopsy. This is the another case report published in 2018 of 58-year-old male with 2-year history of soft tissue painless swelling on plantar aspect of left foot. For this patient, 2 different modalities were used. First was the surgical debulking of the lesion along with the use of oral doxycycline, and patient responded well to the treatment after 6 to 12 months of treatment with repetition of MRI every 3 monthly. And this is the last case report of today's presentation, which was published in 2024, which is of 44-year-old female as a case of cutaneous actinomycosis of left foot and without the history of trauma. She was allergic to penicillin, so doxycycline was used as primary therapeutic agent, and she's responded well to the treatment as well. So to conclude my case, cutaneous or primary cutaneous actinomycosis is a rare disease, especially when involving the lower extremities. Secondly, high suspicion index is required to diagnose this, especially when there is no precipitating factors are involved, like trauma, same in our case. And thirdly, for the management, both medical and surgical therapies go side by side for the optimal recovery. So these are the references I use for the case. Thank you very much for your kind attention. Now, I would like to invite Dr. Sadar Bukhari to further enlighten the case and have few words. Thank you so much. Take care.
Thank you so much, Dr. Afshan, for a wonderful presentation. Dear colleagues, the purpose of choosing this case for our case presentation was basically as actinomycosis is a rare disease, especially the primary cutaneous actinomycosis that really involves the skin, that too without any history of trauma, as basically actinomyces is an endogenous organism and it's a normal flora of the oral mucosa and the pelvic area, but it can be transmitted exogenously via the soil. But as in our case, there was no history of trauma, but the patient presented with the subcutaneous swelling. So the purpose was that the physician must be vigilant and must be thinking of this disease when encountering a case with a subcutaneous swelling on the foot as a differential of actinomycosis. Secondly, as Dr. Afshan mentioned, both medical and surgical treatments go side by side for the optimal treatment management. But as in our case, the lesion was encircling the second, third toes along with the first, second, and third web spaces. So it was not possible to completely excise the tissue without forefoot amputation. So only medical treatment was initiated, and the patient has been given a follow-up plan on the medical treatment with 3 monthly visits in both the dermatology and the infectious disease OPDs, and we will be following the patient for the response if he will be responding, because there are the duration of treatment is very important in this case, as actinomycosis respond very slowly to treatment. So the optimal treatment tenure is almost 12 to 18 months. So we will be looking if the patient is responding well, we will be continuing with this treatment. Otherwise, we will be switching to the second line drugs or opting for the surgical treatment, as the patient at present is not willing for surgery himself. Thank you everyone for your patient listening. Any questions are welcome, please. Okay, as this was the final case presentation, now I would like to invite Dr. Athiya Rahman for her closing remarks on this CPC. Thank you.
Thank you very much for your patient listening and for the comments that you have entered in the chat box. And if anyone would like to comment or have any questions, they are welcome if anybody wants to ask. So I would like to thank all the residents who have put in a lot of hard work to bring this CPC to collect the cases, investigate them thoroughly and the management plans.